everybody. My name is Salia Farrokh. I'm the Neuro-ICU Clinical Pharmacy Specialist at Johns Hopkins Hospital. And today, I'm happy to talk about status epilepticus for our Neurocritical Care Society members. I have nothing to disclose, but I do have some information about off-label use of medications, including anti-epileptics that I will be talking about. So to go over what we're going to talk about today we'll talk about status epilepticus, the definition and how far we've come. We'll talk about the pathophysiology of this disease. We'll talk about different etiologies of status epilepticus. And then finally, we'll obviously talk about treatment options, which is my favorite part as a pharmacist. So based on the new definition of status epilepticus, 5 minutes or longer of continuous seizure activity or recurrent seizure activity without any return to baseline is considered to be status epilepticus. Back in the day, the definition used to be a longer duration of basically unstoppable seizure activity of 30 minutes. But the definition was changed because the idea is that if you're seizing for more than or longer than 5 minutes, it's really hard to stop the seizure activity. And also in animal studies, they found that if you keep seizing for up to 30 minutes, you already have probably lost most of the neurons. So really the benefit of stopping at that point may not be even worth all the interventions, because the damage is basically, most of the damage is already done. So before talking about treatment options, I think it is important to talk about the pathophysiology of this disease, because understanding how this happens can help us identify appropriate and basically effective treatment options. So to guide you through this basically picture that I have here on the right, as you see, initially when we're not seizing in a normal healthy brain, there is a lot of GABA receptors at the synaptic space. But then with continued seizure activity, as you see here, these GABA receptors are internalized and there's less of them to be available to basically act on. But then the opposite really happens with the NMDA receptors, which is the excitatory pathway, unlike GABA, which is the inhibitory pathway, where initially without any seizure activity, there's only few of these receptors at the synaptic space. But then with more seizures, these receptors are externalized and there's more of them at the synaptic space. So it just says that, or what it tells us is that maybe at some point after prolonged seizure activity, there is more NMDA receptors to be acted on, and more of these synaptic spaces that are available for maybe pharmacological interventions. I think when we talk about these pathways and all these pharmacological agents, it could be overwhelming, and it can be. But usually what I like to teach our learners is that when you think about anti-epileptics, think about two separate pathways, and hopefully that can help you, decide what agents to use and kind of get some sort of organization when you're learning them. So the one on the left, the figure on the left is the GABA pathway or the inhibitory pathway. So agents that are working on the GABA basically pathway, the whole intention is that they're activating the GABA pathway, meaning that they're actually helping and they're augmenting the inhibition in the brain, because we think that seizures are these, abnormal neuroexcitation. So, they could do this by either increasing the duration of opening of the chloride channels, which is barbiturates, or increase the frequency of opening of chloride channels, which is benzodiazepines, or some of these agents inhibit the breakdown of enzymes that are responsible for, or they actually inhibit enzymes that are responsible for breakdown of GABA, such as vigabatrin or tiagabin. But then if you look at the right pathway, which is the excitatory pathway or NMDA pathway, basically what happens here is that all these agents that are working on all these different targets, the intention is to inhibit the excitatory pathway. So, they can work on the potassium channel, or they can work on the calcium channel or sodium channel, or they could actually work on the NMDA receptor and inhibit the activation of NMDA receptors by glutamate, or the release of glutamate. And that way, hopefully, when we think about, using different agents, we can think about different pathways and kind of not choosing all of our agents from one pathway. All of this being said, I think it is fair to say that a lot of these agents really do not have a very known mechanism of action. And the fact that there's usually an overlap for what these agents can do. So a lot of these agents probably have a lot of similar mechanism of actions. Now, as far as etiology goes, some acute reasons can lead to status epilepticus, for example, infections, or, TBI, or withdrawal from a drug can do that, or there could be a chronic process. So if somebody has a chronic history of epilepsy, that could potentially be the etiology, especially if they miss a drug or something else happens that can potentially make this more profound. As far as diagnosis goes, all patients should have their blood glucose checked, just because, hypoglycemia or hyperglycemia could mimic some of these, or it could be the reason for people's seizures, and can confound the exam. Vitals should be checked. Head CT is the standard of care. And also laboratory standard labs, should be done, especially if people are on anti-epileptics. Drug levels should be checked. And then continuous EEG should be performed also if that center is capable. And if they're not capable, hopefully there should be an immediate transfer to a center that is capable of doing continuous EEG. Now, what about treatment options? I think, as we all know, the goal should be to get seizures under control and to stop clinical and electrical seizure activity right away. Based on the 2012 Neurocritical Care Society guidelines, we need to basically think about this from two different standpoints. First is the emergent treatment, which is stopping the seizures within the first 5 minutes. But then after that, we also need to think about adding that second agent, or the urgent treatment, to make sure people don't go back to status epilepticus. Benzodiazepines are first-line therapy, and we all know that in institutions where there is established protocol for status epilepticus treatment, outcomes are better, just because rules are more defined and there's an algorithm for when and how to give these medications. This is just the big picture of what the guidelines, the Neurocritical Care Society guidelines, are really, I think, guiding us to do. That obviously the first really few minutes, or I should say seconds, should be thinking about everything that you think about in a critically ill patient. So the ABCDs of critical care, thinking about airway, breathing, hemodynamics, making sure there is an IV access. And then thinking about your emergent treatment, which is your benzodiazepines, which we'll talk more. But then after that, we talk about urgent treatment, which is your second line agent that should happen immediately after your emergent treatment. The question that comes up, I think, all the time is that if time is so important and we should be basically stopping these seizures or seizure activities right away, can we treat these patients before they even come to the hospital? And the answer is yes, and we should really do everything we can to make sure that these patients are controlled as soon as possible. And they look at this basically pre-hospital treatment of patients with the first line treatment or first line regimens. And what they found is that delay in care could potentially reduce your chance of responding to your first line therapy, meaning that if you get treatment within the first 30 minutes, your chance of responding to your first line therapy is up to 80%. But as you see, by time, your response rate will drop. And if you are delaying this by 2 hours or so or longer, your response rate will be less than 50%. This study was published in New England in 2001, where they actually had 3 different arms. They gave placebo to one group, diazepam to another, and lorazepam to the third group. And what they found was that, not surprisingly, patients who received, active treatment, which is diazepam and lorazepam, did better as far as seizure control goes, meaning that more people came to the ED with no seizures. And I think that obviously is basically expected, because you are giving them first-line therapy. But then maybe surprisingly, what they found was that people who received diazepam and lorazepam, they also had better respiratory or cardiac adverse effect profile, which was a surprise, because a lot of the times there's a concern that if you give benzos before intubating or before having, enough resources, you may actually put patients at risk of respiratory or cardiac complications. But the idea here is that stopping seizures right away is probably the best you can do for these patients, even before they come to the hospital, because unstopped seizure activity in the field could be associated with cardiac and respiratory complications, because these people just can't protect their airway with prolonged seizure activity. So that was just something that really proved the fact that you can give benzodiazepines before people come to the ED, before people get admitted, and that has been proven to be effective and safe. Now, when that study came out, there was a lot of discussion about, okay, if that is what we're gonna do, we're supposed to do, what about, IV access? Not everybody has IV access. Not every person can get IV access right away. Is IM an option? So Rampart trial, which is a landmark trial in neurocritical care, was published, and they looked at this, and this was a non-inferiority trial, and what they found was that IM midazolam was at least as effective as IV lorazepam, and it was safe. And as you can see here, actually, IM midazolam did slightly even better than IV lorazepam, but again, remember that it was a non-inferiority study, so you can't really say that it's better. All you can say that it is at least as good or as effective as IV lorazepam, and it was statistically significant. There was no difference in respiratory complications or need for intubation when they looked at these 2 different groups. Now, what do we do? What else do we do? I think we all agree in critical care, things are happening, simultaneously. So at the same time, that there is IV access, blood glucose should be checked. If hypoglycemia is a concern, D50 should be given and thiamine should be given before that. Even if you can't check blood glucose and that's suspicious that you have, you should empirically treat that. If you don't have IV access, we talked about, you can give IM midazolam. Again, if you don't have lorazepam, but you have IV access, diazepam is another option. All benzos are basically acceptable options, and we'll slightly or briefly talk about some minor differences. And if you are really totally out of options, you could try PR or rectal diazepam, which we don't really see or do a lot of it in adults, but there's a lot of that in pediatric patients. So I think, as we talked about this before, and a lot of emphasis on, time to seizure control, that's probably your #1 indicator of how good or how effective your treatment is going to be, or how good your outcome is going to be. And again, lack of IV access should not be a reason for not giving benzodiazepines, because there are other routes that you could give or administer this class. So lorazepam and midazolam are classified as class 1, level A recommendation per the Neurocritical Care Society guidelines. Diazepam is the next one. And really the idea behind this is that pharmacokinetically, we know that, diazepam is very lipophilic. We know that it gets into the brain really fast, but the problem with diazepam is it gets into the brain really fast, but for that reason, because it's very lipophilic, it actually gets out of the brain really fast too. And, its half-life in the intracerebral space or in the CNS is really short. So that could be potentially a limitation. But all that being said, all benzos are acceptable. You know, in the world of drug shortages, if there is a shortage of diazepam or, midazolam or lorazepam, diazepam is still an option, and it should be still considered. And this is really just a study that was done in 1998 or was published, I should say, in 1990, and really, I think, proved the fact that benzos are the first line treatment. They had 4 different arms, and they gave lorazepam or phenobarbital or diazepam plus phenytoin or phenytoin alone. And what they found was that lorazepam was better than all other arms in the study, but then lorazepam wasn't statistically significant, better from the statistical significance compared to other arms, except for the phenytoin arm. So when they looked was that the difference between lorazepam and phenytoin group, that was around 20%, and that was statistically significant, just proving the fact that you know, phenytoin should not really be used as first line. It should be after benzodiazepines as your second line. What about second line, you know, agents, which we'll talk about? You know, that's when we talk about urgent treatment. That's after your emergent treatment. Sometimes we get questions, you know, from our teams or in the ED that, okay, like this patient's status epilepticus, after emergent treatment, do we really have to start them on a second agent or urgent treatment? The idea is that it depends. If you know exactly what the reason or etiology for their status epilepticus is, and you can fix that immediately, probably you're, you know, you could, and if they are seizure free, you're in good shape. But typically that may not be achievable and not be, you know, kind of diagnosed right away. And in most cases, after your emergent treatment, you need to do the urgent treatment for 2 reasons. The first reason is that if your patient's treated with emergent immunotherapy, you need your second line because you want to make sure that they don't go back to your status epilepticus cycle, which is harder to, you know, to treat and stop if it's continued or continuous. But then even more importantly, if they don't respond to your emergent treatment, then obviously you need your second line or other options because you just still need to treat them to get the seizure under control. As I said, we have a lot of evidence to say that I shouldn't say a lot, but we have evidence to say that benzodiazepines are considered first line for status epilepticus. We really don't have a lot of evidence to say what agent should really come next. There's valproic acid, there's phenytoin. You could continue with a continuous infusion of a benzo, usually midazolam because of lack of propylene glycol, phenobarb or Keppra. You know, valproic acid has the reputation of this broad spectrum anti-epileptic, which really what that means is that it, you know, has a very broad mechanism of action. It has GABA effect, it has sodium channel effects and all of that. And, you know, for status epilepticus, the new recommendation is dosing a loading dose of up to 40 mg per kg. It does have some drug-drug interactions because of inhibition of CYP2C19. There is, again, this really kind of to some degree, unpredictable drug-drug interaction with carbapenems that it actually, when the combination is given, valproic acid levels are undetectable. There's many different explanations for this and hypothetical explanation for this, but we think that the metabolism of valproic acid is altered in a sense that the intrahepatic recirculation is not done when it's given with carbapenems, so the combination should be avoided. And obviously it should be avoided in pregnancy. What about phenytoin or phosphonatoin? Again, as we know, phosphonatoin is a prodrug for phenytoin. Phosphonatoin is water soluble, unlike phenytoin that is basically alcohol soluble. Because of this propylene glycol and phenytoin, it cannot be given as fast. We max the rate at 50 milligrams per minute. It cannot be given as IM. It cannot be, basically the risk of phlebitis is high. You never ever should push this drug. Phosphenia, on the other hand, could be basically given faster at 150 milligrams per minute. You can give it as IM, and the risk of phlebitis is lower. And also the cardiac and hemodynamic side effects are also lower. Now, what about, infusions of benzos? Again, as I said, midazolam is the drug of choice. Diazepam and lorazepam both have propylene glycol. All benzos, as we know, have some cardiac and respiratory complications. Midazolam, again, as a drug of choice, it does have some CYP3A4 interactions to be basically mindful of. It goes through significant 3A4 metabolism. It can accumulate in renal failure. The active metabolite is not effectively removed even by hemodialysis. So these are some of the pearls to be aware of. Also, I wanted to kind of highlight the dosing here. The dose that you give for, let's say, a medical ICU patient for sedation is much lower than the dose that you give with, or for status epilepticus. You need to load these patients, and then you need to really be aggressive and bold when you are dosing for status epilepticus. As you can see, technically, you could go as high as 2 milligrams per kilogram per hour. That is not a typo. That actually, in reality, you need to be very aggressive, and you have to be basically bold with dosing these patients, because the longer these patients are in status epilepticus, the harder it is to get them out of status epilepticus. And then barbiturates, which we talked about, as phenobarbital was listed on that second-line agent. They all have hemodynamic side effects, ileus, GI motility issues, drug-drug interactions. All barbiturates are big inducers of CYP. Again, you need to load these patients. And if you, with phenobarb is intermittent dosing, and if you get to, which we'll talk about, more refractory and super refractory cases, you then could put these people on a pentabarb infusion after bolusing them, with the idea that at this point you're basically titrating per EEG, you are losing all of your neuroexam, and basically you're putting your patient in the coma state just to kind of reset the brain activity. What about Keppra? Keppra has gained a lot of popularity these days because of lack of drug-drug interactions, pretty benign side effect profile, although as we know, there's a lot of behavioral side effects, mostly seen in pediatric patients, then especially in the critically ill population. That may not be the most basically pressing complication. The loading dose, as you can see, is much higher than probably a lot of people are comfortable with or have seen before. The 2016 American Epilepsy Society recommended to do as high as 60 mg per kg and max of 4,500 milligrams. It's just, again, the whole idea and concept that in status epilepticus, you have to be aggressive with dosing, you have to be fast, you have to be bold, because the longer your patient stays in status epilepticus, the harder really it is to get them out of the status epilepticus phase. This graph is from the American Epilepsy Society, really in line with the Neurocritical Care Society guideline recommendations. Again, aggressive dosing, very fast, everything happening within minutes of diagnosis. And at every step, obviously, hemodynamic and respiratory status should be monitored closely. Now, as I said, we know that benzodiazepines are first line, but we don't really know what the second line agent, the best agent, should be. So this really brings us to this recent 2019 publication, the ESA trial, that they looked at levetiracetam or Keppra, valproic and phenytoin as second-line agents, and to see if there is one basically superior agent that could be more effective. And they looked at their primary outcome was no basically clinical evidence seizure by 60-minute. And then after initiating that drug, and then they also looked at side effects. So what they found was that there was actually no difference between these agents when you look at improvement in clinical seizure activity within the first 60 minutes from initiation of these agents. When they look at side effects, they did find that patients who received phosphorytoin had more hypertension, and people who received Keppra had more, actually higher rate of mortality, but there was no statistical significance in those findings either in the side effect profile results. What about refractory status epilepticus or super refractory status epilepticus? Again, I think it's good to review the definitions because, you know, sometimes we get lost in all these, you know, different terminology. So we talked about, you know, status epilepticus, and refractory is when our patients are not responding to benzos and now a second anti-epileptic drug. When you get to super refractory status epilepticus, that's actually when your patients continue to have seizures for over 24 hours despite being on an anesthetic agent. What do you do in these cases, in refractory or super refractory cases? The answer is we don't really know. It's hard, and you know, I'm sure everybody who's been in that position, you kind of feel like you're out of options, but options that usually come up are, you know, are we going to do ketamine? Should we do propofol, or commit our patients to pentabar, which technically means really no neuro exam for days? You know, I think propofol has a lot of issues because, you know, when you talk about against status epilepticus, you want to be dosing aggressively with propofol. You bolus them, you know, unlike putting it on for sedation only. You bolus with the with high dose of propofol. You put them on a high dose of continuous infusion. And obviously that can put people at risk of hemodynamic instability. People need to be intubated. People may have, may develop PRIS, which is the propofol-related infusion syndrome, which is, you know, basically associated with metabolic complications such as metabolic acidosis, rhabdomyolysis, and ultimately cardiac arrhythmias. Pentabar, again, as we talked about, it can be associated with a lot of side effects, including ileus, you know, immune system modulation, high risk of infections, drug-drug interactions, loss of neuroexam. Ketamine has, to some degree, I think, gained some popularity as an NMDA receptor antagonist. It's a drug that has a very unique mechanism of action compared to all the other agents that do GABA, you know, activation. It doesn't suppress your basically cardiac function, or it, to some degree, there is some evidence that it could cause more tachycardia. It shouldn't be associated with respiratory depression. There is obviously some dose-related issues. Obviously, if you put people on the anesthetic dosing, that's, I think, the discussion is different with the respiratory drive and all of that. But the dosing is also, as you can see, in ketamine, for ketamine, is much higher. So instead of dosing, you know, 0.1 to 0.5 mg per kg per hour for analgesia dosing, which we see in our chronic, you know, pain population, the dose is very much more aggressive. We're loading our patients with 1 to 5 mg per kg and then continuous infusions of up to 10 mg per kg per hour. This is just to review some, you know, studies that looked at ketamine. It looks like most of these patients and most studies are talking about starting maybe ketamine when people are in prolonged seizure activity. As you see, most of these patients started ketamine from any time from 5 days after their initial status epilepticus diagnosis up to 58 days or longer. And this may explain that because your NMDA receptor upregulation happens later on, that may explain why this has been something that the observation that I've seen. It also highlights the fact that, you know, your dosing recommendation or regimen should be more aggressive than your typical analgesia dosing. And if you're using a lower dose and you are not seeing the effects that you should see, it's probably because of underdosing these patients. What about newer agents? Just again, because, you know, especially when we get to refractory and status and refractory and super refractory status epilepticus, at this point, we're ready to try anything and everything. So this was a study that was published by a group not that long ago, about a year ago, looking at you know, all these newer agents that have been, you know, been on the market over the past 10 years. looking at brivaracetam, clobazam, lacosamide, perampanel, rufinamide, and stiripentol. As you can see, not a whole lot of, really randomized control trials, a lot of retrospective, a lot of case reports. Lacosamide, again, may be the one with the highest level of evidence that we think that it may be helpful, especially in focal seizures and focal status epilepticus cases. We know that with lacosamide, if you load with a 300 or 400 milligram dose and put patients to doses of up to 400 milligrams per day or even higher, if they could tolerate and they do not have, EKG or PR abnormalities or prolongation, that may be effective. And as you see, all the other agents, pretty much there are case reports that there is this wide range of response rate. And more importantly, a lot of these studies defined response rate differently. So it's really hard to put it all together and make a big conclusion given all these different case reports and different retrospective reviews. I think this presentation will be incomplete if we don't talk about some important clinical pearls. Loading doses should be, again, aggressive and should be done regardless of patient's renal or hepatic function. If there is a suspicion for isoniazid toxicity, we should think about vitamin B6 immediately. If eclampsia is the reason for status epilepticus, we know that it requires its own therapeutic pathway, which is high dose magnesium and a continuous infusion of magnesium. And then, usually we get questions about, okay, we have a continuous infusion of ketamine or a benzo and seizures under control. How do we go about de-seeing them? Usually, again, based on the 2012 guideline, we try to keep patients on the continuous infusion for 24 hours to make sure that they're seizure free. And then we work the next 24 hours to get them or titrate these medications or these infusions off. If the drug is more lipophilic, I think it's fair to say that you could titrate down faster just because your body and your fat tissues are acting as auto tapers. Now, in very highly refractory cases, we become creative. We've done, immune therapies such as IVIG or plasmapheresis, or especially in pediatric patients, there's been a lot of great positive evidence with ketogenic diet. Again, if you are having a lot of issues with hypertension when you're using propofol or barbiturates or benzos, remember that ketamine could potentially help you with sparing vasoactive agents, which we've seen in different studies. So in conclusion, benzodiazepines are considered first-line therapy for status epilepticus management. Evidence really does not support superiority of one drug or one class as second-line agent. I think that's still something that we're not sure about. What should be the golden second-line agent? I think optimal dose and duration still remain unclear. A lot of, I think, trials and errors we're still doing in this population. And also, finally, evidence is insufficient to support the use of new anti-epileptics for the treatment of status epilepticus refractory or super refractory status epilepticus. With that, I would like to finish on this lecture and happy to see you soon. Bye.